Hi guys, this is Christina Toon from Atlanta, Georgia, and I will be doing my case presentation today on benign paroxysmal positional vertigo, otherwise known as BPPV. Okay, so I'll talk about the patient profile. The patient is a 21-year-old female college student, and she presented to the clinic on April 30th, and she did have a referring diagnosis of BPPV. Her chief complaints were vertigo, dizziness, and vomiting due to her symptoms, and then also the inability to focus. She's been having these bouts of dizziness or vertigo for the past 4 weeks, and her first episode was on April 4th, and it was insidious in nature when she woke up and had extreme vertigo. The outcome tool that we used was the Dizziness Handicap Inventory, and she scored a 76. The scale goes from 0 to 100. And so on the scale she was quite severe for the DHI. Okay, so on the body diagram we only have one area, and I kind of just pointed to the head because it's near her left ear. As you can see from the body diagram, we have only one primary complaint or one problem, which is the vertigo, dizziness, and eye twitching. Later we'll find out through the objective exam that it was the left inner ear vestibular system. Okay, so with planning the exam with a BPPV patient or a vestibular patient, we have to consider the different canals that the otolith might be floating around in and how the patient will present with these different nystagmus or different tests to rule in, rule out which canal it might be in. We also need to make sure that we look at the vestibular system in general, the inner ear, cervical spine, cerebellum, and then the brainstem, vestibular nuclei. All of these structures may refer to the area and to the direct symptoms that the patient is coming in with complaints of. Okay, so my pre-interview hypotheses, my primary is BPPV, and throughout the history I will try to rule in if it's canalithiasis or cupulolithiasis, also which canal it may be in, through the objective exam. Secondary is vestibular hypofunction, tertiary is central lesion or central involvement, and then other hypotheses that I need to rule out would be migraine-like symptoms, Meniere's, vestibular neuritis, Arnold-Chiari, or cervicogenic vertigo and dizziness. Okay, so the symptom behaviors. For P1, for aggravating factors, the patient expressed looking up as being very hard for her to do and causes her symptoms to reproduce. And pretty much any movement of her head, and then laying down in her bed was also another one that was very hard for her to do, and closing her eyes. So for time to onset of the aggravating factors was pretty immediate. As soon as she would either look up or move her head, she was feeling that severe vertigo. And then the easing factors were medication that she'd been given to help with her dizziness, and then resting in a seated position with her eyes open. And the time to ease was usually seconds to minutes. So for the sleep in 24-hour pattern, the patient was not able to sleep well because of the spinning sensation that she would get when she would lie down, when she would roll over in bed, or when she would close her eyes. And the 24-hour pattern, from the beginning, she had that first episode on April 4th, and she got some medicine for a sinus infection from the clinic that was at her school, and she said she felt better for a few days after that, and then a few days later the vertigo would come back, and so it was kind of these episodic periods that she would have the severe vertigo and spinning, and for a few days she would be better, and then it would get worse again. So it was pretty episodic for the past 4 weeks, and it seemed as though as the weeks went by it got more intense vertigo, and she had less duration between good days and she had more bad days. The mechanism of injury is insidious in nature, and significant prior history. Patient has not experienced any recent falls, although she was trying to ambulate with her mother by her side because she was nervous about falling, and any head movements were causing her to have that spinning sensation, which made her uneasy. She did indicate that on the intake form that she has had headaches in the past year, and we talked about this with her history and subjective information, and she said that her headaches were due to stress from school and that they were not associated with the current symptoms that she was experiencing. So with the red flags that we put down, the nausea, vomiting, dizziness, vertigo, and gait disturbances, we really want to make sure that these are a part of BPPV and not something that may be going on with the central system. Especially with the gait disturbances, making sure that she doesn't have some kind of ataxia or something going on, and we really want to make sure that the vertigo is a direct relationship with BPPV. Yellow flag screening, she didn't have any. And special questions, she did visit the ER 3 times within the past 4 weeks because of the severe vertigo and spinning that she was experiencing. She did have a CT scan done, and she had x-rays done, which ruled out some of the central issues that we might be dealing with. And she has been taking medication for her dizziness, which she reports has been helping her. Okay, so for the asterisk signs, from the history, patient reported that she was having difficulty with looking up. It didn't even have to do with head movements, it was really just looking up, and she would feel her symptoms increase with looking up. So that was one of our asterisk signs. Being able to ambulate independently, rolling over in bed, and then also laying down to sleep with her eyes closed is another asterisk sign. Okay, so following the history, our primary hypothesis is still BPPV, and I'm going to lean more towards canalithiasis right now because her aggravating and easing symptoms, easing was within seconds to minutes, that she would feel the severe vertigo start to diminish. Secondary is still vestibular hypofunction, and then central lesion, and some other competing or migraine-like symptoms, Meniere's, Arnold Chiari, cervicogenic dizziness, and vertigo. And with my initial hypothesis, honestly, I wasn't quite sure if I could rule out much yet, but I know that with vestibular hypofunction regarding the vertigo component, we can partially rule out that because it usually will last minutes to hours with vestibular hypofunction, especially during the acute time, and so we know that her symptoms do ease in seconds to minutes. Okay, so with the SINs, we have the severity. I would say she's at a moderate level because she's having severe vertigo, and she experiences this vertigo pretty much right away with any kind of head movement, eye movement, and she's been unable to perform her activities of daily living during these episodic periods of intense vertigo. Irritability is severe as well, due to the nature of any head movements. Any kind of slight eye movements will cause that extreme vertigo also. And she's been unable to drive, unable to sleep, and unable to ambulate independently. Her problem is vestibular in nature, and the stage is acute subacute. Her symptoms are reproducible, and they're pretty much staying the same at this point. And her symptoms are also more episodic. Asterisk signs are reproducible with head and eye movements. So to rule in and rule out our top 3 hypotheses, we will do the Diggs-Hallpike maneuver, and that's to rule in, rule out BPPV. And then VOR head thrust test I would like to do to rule in or rule out vestibular hypofunction, and then saccades and smooth pursuit will also be done to test for central deficits or central involvement. An item that I would like to defer for day 1, 2, or 3 would be the cervical screen, and the reason for this was due to the patient's high irritability and severity of symptoms. Okay, so the 4 tests that were done were smooth pursuit, saccades, VOR head thrust, and the Diggs-Hallpike, and smooth pursuit, saccades, and VOR were all negative. And she did great on all those tests, and then Diggs-Hallpike was the only one that reproduced her symptoms, which were fairly severe when we put her into the aggravating position. And she also did have a left upbeating torsional nystagmus when we turned her to the left side and brought her down, which is indicative of a posterior canal BPPV. So at this point following the exam, my primary hypothesis still stands as BPPV canalithiasis in the posterior canal on the left inner ear. And with my historical asterisk signs, I'll use walking independently, rolling in bed, looking up, bending over, turning the head fast, or closing her eyes. And with the physical exam, we had a positive Dix-Hallpike, which will be reassessed the next time that the patient comes in. So with the plan of care and the prognosis for the patient, I do expect a full recovery of full functioning of the patient. And based off research and articles that we have, that within 2 to 3 sessions with the patient, she should be back to full functioning without any symptoms. So I expect to see her 2 to 3 times depending on her symptoms. She would like to go to sleep again a full night without symptom reproduction. She would like to be able to ride a horse, and she would like to drive independently. And if she was not making progress, and this will kind of go into the overall management strategy as well, after about 3 total visits and doing the canalith repositioning maneuver, we would like to just kind of go back and see if we're possibly missing a cupulolithiasis or some kind of other vestibular related problem, and then it's at the point where do we refer her to another physical therapist with more experience, or possibly to another physician if we feel as though she should be referred, if we have exhausted all other measures of possibly looking into other vestibular related issues. And if you have any questions, please just post them on the board and I'll try to answer them.